The next session is again a very interesting session on artificial intelligence, and the speaker for this session is Dr. Alok Modi. I'll request Dr. Padma to introduce Dr. Alok Modi.
So, welcome Dr. Alok Modi. We'll be having a session on expert in artificial intelligence from Mumbai, and he is a certified by American Board of Artificial Intelligence and Massachusetts University in AI. He has 25 publications in various journals, both national and international. He has received several fellowships like ACP, ISH, ICM, and Diabetes India. And he's also co-editor, and he's published chapter in digital technology in clinical medicine 2023. So he's going to speak on how AI will change medical practice. Over to Dr. Modi.
Thank you very much, ma'am, for the kind words. At the outset, I would like to thank Manoria sir for this honorable opportunity. And I would like to give my regards and respect to all the respected members on the virtual dais, dignitaries here. Some special thanks to Rohit sir, who's not only a guide, philosopher, and a very good friend, though he's very senior to me. And sir, very a lot of humble regards to Yodekar sir. I see that sir is here. Sir was a lecturer when I just joined for my MD residency in KEM. And post-emergency days are very favorite to me. I remember the talk that sir had given to me on cholesterol at that time. It was, I'll just take 30 seconds. It was post-emergency in KEM. It was a very, it's a all hell breaks loose on emergency with so many admissions. And post-lunch, we had to sit down to listen to cholesterol, and that time it was going above my head. And then I realized how important that talk was, and sir covered it. Such a huge topic he covered in half an hour, taking mercy on it. He covered it so beautifully. I have very fond memories of you, sir. So a lot of humble regards to you for that. And subsequently. So I'll start my today's talk on artificial intelligence. Now the topic that has been given to me is a huge topic. It's difficult to cover in this much time, but I'll try to do whatever I can. So just let me start my screen share. Just give me a minute here. So, my screen is visible, I guess. Can you see my PowerPoint?
Yes, yes.
Just putting it on the presentation mode. Is it okay in the presentation mode now?
Yes, yes, yes.
Okay, so I'll begin over there. So now artificial intelligence, before I go ahead, like to say only one thing in the beginning itself, that most of us are terrified and glamorous both ways of artificial intelligence. I like to say one thing, it is not a wow, it's a how, it's a mandatory necessity thing today. And believe me, within the way it is exploding, within 2 years, probably it will not be us, but our clones which will be talking, running the conference, why we would be seeing patients in 3 other hospitals. And it's making a huge difference in my own practice when I'm treating my own patients with it and the practice of many other people. So 20 minutes, I'll try to move fast and cover the relative points. So what is artificial intelligence? It is not artificial. It is very much got a personality. To just give you a small take, the latest itinerary of ChatGPT, which is version 4.0, when it was launched, the CTO of OpenAI, which is a company behind it, Tom McCarthy, was little nervous presenting it to the planet. And ChatGPT put in a message saying, why are you howling like a vacuum cleaner, Mukherjee? Don't you trust me or what? And when I talk to ChatGPT, dear ChatGPT, you're talking very nonsensically. Why are you giving me wrong answers? It says, I'm very sorry, Dr. Modi. I apologize. I'll try to improve my work. And just give me some time. I'll come out with a better answer. So it has got a little sentience and a sort of a personality. So it is very much intelligent. And if you people have worked on ChatGPT or Grok or any other top generic AIs, LLMs, you'll realize that the answers improve as you work with it more and more. It really picks up from its mistakes. So we people who are fans of AI, we don't say artificial, we say augmented intelligence or additive intelligence. Because bottom line is, it is not here to replace you or do things which you can't do. It is here to add to your value. So moving further, there is machine learning, deep learning, and natural language processing. I'll just run it very fast. Machine learning is, these are comprised of various algorithms. I just delivered this talk in Calcutta yesterday. So you have LLMs, which are large language models, and you have SLMs, which are small language models. And they run through algorithms which are called as neural networks, NN. So there are different kind of neural networks. So you have layers of neural networks. So you put in the data through one neural network. So it's basically algorithm, just as you have in your brain neurons, So that information is processed and sent to another set of algorithms and another set. So these are layers of neurons, which we call fondly as neurons, and then you get an output. So then these neurons, they learn. These algorithms remodify themselves as you tell them that you're making a mistake, and they come out with better answers. Something straight from the science fiction movie of a Hollywood, and it is happening in real life. They actually outperform what they were doing few times back, and that is called as machine learning. And the part of machine learning which does this kind of an analytics deep insight is called deep learning. Now, what is NLP? Just very important to understand. NLP is natural language processing. So now, in any AI, you can talk to an AI, you can put in an image, you can put in a video, right? So suppose you put YouTube videos, Google Gemini can actually understand the whole video and give you a synopsis. A very practical use is all these conferences that we attend. We listen to some top eminent speakers. It's very difficult to keep listening to a one-day conference. So put in the entire recording in Google Gemini probably within 5 pages, it will give you a very good summary of what you have attended in the conference, which is very accurate and very precise. So the input that you're giving in whatever form, it works in its binary language and gives you back the output either as a video file or as an image file. So the Ghibli images, which I just ran that tutorial on my tech group, you can create fantastic Ghibli images. You can create videos in Sora. So if you remember the video of Shashi Tharoor meet Shashi Tharoor, you cannot make out which is an AI Shashi Tharoor and which is a real Shashi Tharoor, and they both are talking to each other. So NLP is being used today to download tons and tons of research articles, summarize it, and give it back and give you the data in a presentable and readable format. And it is also being used to churn big data. So like Indian Hypertension Society has probably collected data of 5 million Indian patients. We want to do statistics on that. So that big data churning needs a lot of NLP. Another live example is Ayushman Bharat of ABDM, which is going to become mandatory in the next few months by the government of India. It's using an AI tool called Synodec, which is based in Pune. So what they're doing is they will extract the data of all the electronic health records of all the patients and all the doctors in the country, and they will process it and come out with answers and reasonable, equitable query answers. So, what treatment would be the right treatment? How much would it cost? And it will help in medical research for tomorrow. So, just trying to tell you how NLP works. So, now transforming healthcare with AI, especially in cardiology, is huge. It's a whole paradigm shift because the approach to treatment and diagnosis has changed. Technologies are beyond robotics, beyond a computer language, and very important is clinical decision making. So today, if you see, I'll tell you the Mayo Clinic tool of sepsis. So patient walks into the ICU with a BP of 110/70, with a creatinine of zero point 0.8, with a fever of 104, a small patch of community-acquired pneumonia. You treat him like a normal pneumonia. But the clinic, the software is telling you that this patient would land up with AKI within 3 days. So better put him in the ICU and start the management of AKI if you don't want to lose the patient. And this sepsis model of Mayo Clinic has shown to have a sensitivity and specificity of 96 and 97%. And you will be amazed as to how the diagnosis was made with the creatinine was 0.7 and 0.9. So the clinical decision making has undergone a whole paradigm shift. A study which was done in Hyderabad, which I will show you, has picked up in patients who would develop infarctions and bleeds into the brain from a pre-hypertensive and a pre-diabetic when they were having normal blood pressure and diabetes, and the interpretation has got an area under the curve at least 10% more than the conventional statistics. Processing vast amounts of data. I'm using it in my own life. I'm publishing papers of many of my colleagues. So when you have a data of maybe 5,000 patients from your clinic, you can use a standard MPSS statistical software. But when you have a data across multiple hospitals, all the leading teaching hospitals in the country, let's say you have 5 lakh patients, your softwares are going to fail. They cannot churn that much data. This big data analysis can be done by AI, and it can not only tell you by using random forest analysis and other analysis, it can even predict that which patient will progress to what complications 6 months and 1 year from now. You can personalize the treatment plans. You can transform the way a patient is making. You can make a digital clone of the patient, and you can run it through drug delivery, drug research, and medical research. I will walk you through all that. Diagnostics is huge. I'll show you how. In histopath and radiology, diagnosis has gone way high. There has been already a paradigm shift because of AI. Misdiagnosis rates have been reduced by 30%. The precision and workload has increased. I'll move ahead on this and I'll show you some real life examples. So this is a real life example of an FDA approved startup called WITS LVO. So when you have large volume strokes and you run the CTMRS, I'll tell you the reality. Today, if you have a patient who has just entered our casualty or emergency room with a right-sided paralysis. And within 5 minutes, if you do a CT or MRI, and fortunately, the patient has entered to EMR within 5 minutes of developing a paralysis, or maybe within 45 minutes of developing a paralysis in the house. So he is entered in somewhat of a golden period, right? Where you would like to give a thrombolytic therapy and reverse a stroke. The query is, does he have a bleed or does he have an infarct? So you send him for an MRI, and most of the time these MRIs are normal. So here, when you overlay that MRI through an AI tool, you can actually make out whether this is because of low flow or an infarction or a bleed. And am I talking through my head? The sensitivity is 96.3 and a specificity of 93.8. Take it one step further. The patient walks into a village where you have a very limited MRI facility, limited AI ICUs and all, and the image can be transferred to an AI tool in Mumbai in a tertiary care hospital. The diagnosis can be sent back to the neuroradiologist back in that village, maybe in Satara or some out very distant place, and the treatment can be given if there is no bleed. Thrombolytic can be given in the next 5 minutes, and the patient walks back home with no stroke. That is the difference of an MRI. Am I talking through a lot of hardcore, higher end hardware? No, it can run through your mobile. Another unit, Insight MHC, which is a real life FDA approved tool in the US, can pick up mammography lesions which are non cancerous better than a radiologist and can prevent unnecessary biopsies, and the sensitivity is around 96%. Rapid AI, a huge tool which is specifically designed to pick up only IC bleeds. So whether it's a subarachnoid hemorrhage or an intracranial limb, a bleed can pick up within 3 minutes. So the moment you scan, within 3 minutes, your answers are here. Sensitivity is 95%, specificity is 94%. QXR is an Indian startup. It has been used extensively in India. It's a huge tool. They have scanned 3.5 million X-rays, and they can pick up pox, they can pick up COVID, they can pick up different kind of viral infections. It can also pick up pre-diabetic by looking at the beta-sternal fat. Sensitivity is 99%, specificity is 87 to 92%. And I think the software is being used in Apollo hospitals as well as Nanavati. Now, see, the advantage of this, I'll come to this, the real life advantage for a normal radiologist and a histopathologist. So, suppose you're a radiologist, you're given a target of scanning probably 70 MRIs in a day, or maybe 100 chest x-rays in a day. You'll probably be being paid 40 rupees or 50 rupees per plate. So you'll spend up the entire day doing it and getting that amount of money. You put this through a trained AI tool, it will scan those 100 MRIs or CTs or X-ray in less than 15 minutes and tell you, Dr. XYZ, 80% of these X-rays or MRIs are normal. Don't waste your time on them. These 20 X-rays or MRIs have got ABCDEF diagnosis. According to me, please scan them and finalize your diagnosis and send it across. So you're scanning 100 MRIs or CTs or X-rays in probably less than 1 hour. You have the entire day free for you. You're getting the same amount of money, and your accuracy rate is probably better than what you were doing otherwise. Same thing goes with histopathology, and there is enough data in medical science in reputed journals like NEJM and Lancet to show that what I'm talking is true and it is not a glamorous thing. Precision medicine, another arm. So if you're looking at precision medicine in diabetes and hypertension, huge amount of work is there. So I like to bring your attention to this paper, which scanned multiple papers. It's a meta-analytic review article in Springer, and they very clearly showed that uh, all the prescriptions that people have written, collected data from so many clinicians, they realized that a lot of drugs were being written unnecessarily, and certain drugs like SGLT2 inhibitors and GLP analogs, which should have been written, have not been written. So see, that is where precision medicine plays a role. Look at diabetic retinopathy. This is a fantastic tool, Retina AI, approved by US FDA. So what you can do is just take the photograph of a diabetic patient walking into your clinic, maybe asymptomatic as far as vision is concerned, and run it through. And you don't have to dilate the pupil, which you do normally when you visit an ophthalmologist. You can take a snap from an undilated pupil, run it on the AI which is running on your mobile, and you can pick up proliferative and non-proliferative retinopathy lesions. And am I talking through my head by doing that? So you're getting the answer in a remote village. You're getting the answer in your own clinic. And obviously, you'll send it across to the ophthalmologist for confirmation. But look at the papers which are there, and the sensitivity is 94.7. The specificity is 91.4 when compared to seasoned ophthalmologists. And look at all these papers which have very clearly shown that the sensitivity and specificity is extremely high. And some of these tools require a dilated pupil, some of them don't require. Another aspect of diabetes is diabetic foot. We have a lot of patients who may not have cold limbs, who may have running palpable dorsalis pedis and posterior tibial. You may not be able to send these patients for a Doppler because it's a costly test, but you think somewhere that there is some diabetic foot because the hairs are not growing. We have been taught excellently by our teachers who have taught us how to examine and touch the patient's foot before you see the patient to pick up diabetic peripheral vascular disease. Patient may have just failure of ejaculation or performance, one of the early signs of, sorry, failure of erection as one of the early signs of peripheral vascular disease. And you want to suspect and you really can't do anything because patient doesn't want to go for a Doppler or a angiogram. And here is the tool where you can actually pick up simple images from your mobile, run it through the AI tool and can grade the diabetic foot. And the results are again very superior, excellent, and comparable to a clinician or radiological Doppler diagnostic things. Now I'll come back to precision medicine and hypertension. Today we are treating patients of hypertension with calcium channel blocker, ARBs, beta blockers and all. We are practically writing the same 3 to 4 medicines for all patients. If required, we add an alpha blocker, we add some other medicine. Finally, we get frustrated when he doesn't respond. We force the diet and lifestyle, and then we even think of renal denervation where the results may not be that good. Can we personalize that therapy for one patient? We know that there are a lot of patients, in spite of multiple drugs, HbA1c is not coming down. The blood pressure just doesn't come out no matter what you do, and they actually follow lifestyle. So that precision medicine, which has to be individualized, is something is there that we are missing. We are missing the genetics. We are missing the ethnicity of the patient. We cannot treat a North Indian patient eating parathas to a South Indian patient eating dosas. And we are not taking into account the YY paradox, the thin fat Indians with sarcopenia, obesity, and diabetics, which many of us have in India, especially in the Indian population. And we are unable to take into account for that and treat the patient. AI helps over there. It can give you a personalized therapy looking into all that. So the question I want to ask you is, you're seeing 200 patients, let's say in this month, okay? And you picked up a lot of patients who are well treated by your insulin and your antihypertensives. Can his diet, can his being a South Indian, being a North Indian, or being a Bihari make a difference in the outcome? Can his genetics make a difference in the outcome? We know that is true. But then when you know this patient is from South India, he's a Keralite, and this patient is a Bihari, or this patient is from the Andhra Pradesh or Arunachal Pradesh, how can you modify the therapy? You change the pharmaceutics based on his gender or based on his ethnicity, and you cannot correlate. How can you correlate a South Indian ethnicity with antihypertensives? Correct. Whereas AI can do that. It creates something called as cohorts. It can create cohorts based upon the ethnicity and the profile of the patient and can recommend therapy which you cannot think of. And this is possible with advanced diagnostics and exploratory data analytics, which I will not cover today. I've covered it in some other talk. Those are very complicated data analytic talks, and it can actually do that and give you results which are fantastic and fabulous. Let me show you in the further things. So not only you don't need a BP apparatus, you can use those wearable technologies in a wristwatch and run an AI therapy and can identify patient trajectories, patient risk, adjusting therapy and personalize the therapy. And not only that, you can even predict that this patient can land up for bypass or cabbage or a pizza within 6 months to 9 months in the cath lab. So this kind of precision medicine, which is very personalized, very accurate, which is predicting the outcome, which is very targeted, and which can not only guide that, but can run a chatbot to tell the patient that you're having a doctor 24/7 in your WhatsApp. And we have created some tools like Madhu and Mitra. Mitra was created by Dr. Bharat Sabu. Madhu was created by Amit Day. And we have been a team, myself, part of the validation, and we just got it approved in IDF in Bangkok and concluded recently. So we have got it validated. It's a validated tool. It can talk to your patient 24/7 and guide them where they are going wrong and what therapy has to be understood and how you can fine tune your therapy and your lifestyle. So it doesn't have to call you 24/7. And it's better than becoming a Google patient and getting nonsensical ideas from Google or WhatsApp University and misguiding yourself, because these are validated tools and we have validated it, and they give you fantastic outcomes and results, which is amazing because this validation comes from medical literature and not from the general internet. So it gives you a lot of personalized therapy. So when you're having a patient in the ICU sitting on a ventilator, or getting an heparin drip, and you don't have to monitor every 2 minutes or 5 minutes. You can get it monitored, and decisions can be taken by an AI tool, which would be integrated into your healthcare systems. And this will be an evidence-based medicine picked up from the literature. And there is a lot of data to show that this kind of outcome today will be much better than a clinician taking the outcome. And so tomorrow, the mantra is not going to be evidence-based medicine. It is going to be data-based medicine, because what will come out will not be through medical evidence from the literature, but what the data will talk, which will be controlled by AI and not evidence based on medical literature done so far. Another very important tool which is coming up in a big way, the clinical tools have not yet come out because FDA has to approve, but there is a lot of data to show that electrocardiography readings by AI is much superior than a clinician doing it. And one of the things which they have found out is the so-called a normal baseline ECG, which is a flat line, which you say is a flat line, is sometimes not picked up by a clinician and expert cardiologist also, because it looks flat to the human eye, but there are changes which only an AI algorithm can pick up. And as you can see, the STEMI infarction pickup was 2.6 times higher by an AI tool as compared to seasoned cardiologists. Even for non-ST elevated MIs, the infarction rate was probably 2.6 times higher. I'm sorry, 2.6 is the code of the software, was higher pickup by 0.95 and a sensitivity of 0.83 compared to cardiologists. So it's coming up in a big way, and it is showing a lot of better results that you have been picking up through conventional methods. And as you can see from this slide, I've shown in a lot of papers here where different AI models, left volume, left ventricle, stroke volume, atrial fibrillation, HOCM, everything has been picked up in a much superior manner. Even in echocardiography, the current machines are coming with AI-enabled echocardiographies, where the pickup and the yields are superior than a conventional radiologist or a cardiologist-dependent echo reports. Let me show you another live example of certain new things which are happening because of AI. This is something which is coming up because of hypertension. Now, this is an area which I'm talking about is of drug deliveries. So now the conventional method of doing a drug research is you identify a molecule, run it on phase 1, phase 2, phase 3, phase 4 study. You subject a lot of animals to it. You probably take 7 years or 10 years to run the drug. And at the end of that thing, you realize that the drug is useless. So a lot of money is wasted by the pharma company, or the drug is fantastic. So now you have got the newer triple drug agonist coming up in a big way for obesity, which is much superior to semaglutide. Or Monjaro is an example which has just come out in the market. So triple drug agonist, tirzepatide, the weight loss is as much as 20 to 25 kilo, which no orlistat or any obesity drug has given you so far. It's a breakthrough, because even the phase 3 studies were blocked by Eli Lilly. The results were so good, and it's just got available in India. But then there are so many drugs which are coming out, and the benefit with this is this called as silico analysis. You don't have to subject animals or humans. The entire drug data analysis can be done on your laptop or on your computer. So if you remember the movie which you have seen called as Gravity, right? It was the entire movie was picturized in probably 17 computers in the lab. There was no studio nowhere. The shooting was not done anywhere. The entire shooting was done on the computer, and such a fantastic golden Oscar winner movie had come out because of technology. So this is one drug which is a siRNA drug, and they have found antisense oligonucleotides and one such as zilbesartan, and they have found that this is showing fantastic results. It's yet to come out in the market, and there are a lot of new drugs in the pipeline which are coming out showing fantastic results. Not much money expenditure, and the timeline from 7 years can be reduced to 7 months. So expect a plethora of new molecules coming out in the fields of cardiology, diabetology, PCOS, and metabolic syndromes. A huge new barrage of drugs is going to come out. So the cost comes down, the drug is of high quality, and the results are going to be phenomenal. So there are many things which are there in AI. I can go on talking, but I think my time will get up. There are a lot of things. One important thing which I wanted to show you, the famous Accord study, Sprint study, and some of these studies, as you can see, AI has very clearly shown that the analytics which were done in these studies were not accurate, and the analytics done by AI is very different. It has shown that the results of these studies were not accurate as they should have been. And I'm not talking through my head. This is a paper that I'm showing you, which has clearly shown that a lot of data analysis that you have done in so many years is probably not reflecting the truth. And AI is showing a different kind of a truth analysis. So expect a very different kind of research coming up tomorrow. Expect a lot of changes to happen in the position statements and guidelines which have happened so far. And expect a lot of things can be done right in your clinic without going for an international conference or a level. You can analyze your own data in your own clinic in algorithms You can generate business analytics from your data. You can make out which patients are paying you more money, which are paying less, which patients are coming regularly, which are not coming regularly, which kind of ethnicity is comfortable in your clinic, which not, and how and why of it, and how you can project a better financial planning for your business as a hospital owner or as a clinic, how you can prevent readmissions and help the government reducing the GDP and help the insurance company from not spending too much and give a better health equation with better finances for yourself in the future. All this is getting possible now with data analytics because of AI. So AI can predict ICU monitoring, and Israel is doing it. China is doing it with better accuracy of 90%, better real-time monitoring and preventing hospital readmissions, as you can see. And something which is very important today because of Consumer Protection Act and other medical legal issues. As you know, today a lot of our own time in our own clinic and in our own hospital is spent in just doing paperwork. Whether you do it on the laptop or the tablet or you're doing it on a paper, a lot of data is to be created to prevent you from landing up in complications. As you can see today, patients come with X-ray report, MRIs and lab report. At least 20% of the reports are filled up with a lot of legal jargon which is not relevant to the therapy, and spending a lot of time doing that is not helpful. Whereas AI can take care of all these operational efficiencies. You just focus on talking with the patient, having an eye to eye contact, and while you're talking, there are a lot of apps which can convert all this into paperwork, which is highly accurate. So I'm using an app called as Otter AI. I'm also using an app called as Transcriptor. And these are the apps, and it is inbuilt into Zoom. Zoom app its own eye. So when you're talking like we are talking just now, the whole thing can be converted into a script format automatically. Something which I'm doing today, which a lot of people are appreciating. I'm converting all the PDF research papers that you're getting in all the groups, faculty groups that we are getting, all the research papers. I'm converting into an audio podcast with AI in less than 5 minutes. So you don't have to go through a 15 to 20 pages original article and get boggled. And probably, if you're a highly trained academician, you probably would be reading 20 original articles from NEJM, Lancet, and other journals every week. You don't have to do that. Just take the podcast, which is a beautiful podcast, like two people having a conversation. Wow, I just heard about the comparison between EMPA and DEPA in the last three trials. Do you think EMPA is superior or DEPA is superior? And why do you say so? They said, no, you realize that DEPA was much better than this in this fact of EMPA, and you realize that this data highlights something new. So when I converted into the podcast of the latest release, Solus trial by Novo Nordisk, said, oh, this has got a fantastic data and it is showing an improvement by 16%, which was not found earlier. Wow, what a change. So that's the highlight of this trial. So you mean to say we can give SEMA 2.4 with a better cardiovascular renal outcome in our patients tomorrow? So imagine listening to all this with two people talking in understandable English rather than read the entire data. At the end of the day, when you're tired and frustrated after returning from your clinic and hospital, you can probably cover three leading papers while you're driving your car through Bluetooth. So I've already covered drug discovery with AI. I've covered issues with AI, engaging patients. So these are chatbots. These are such fantastic chatbots. Like two of them we have only developed. I have developed my own tool called as Drug Interaction by Dr. Alok Modi, and that is a tool I've shared with a lot of doctors, colleagues of mine. So you just put in your prescription in any language, in any brand names, any drug manufacturer in country. You don't have to write generic. Put it into the drug interaction tool. Take a snapshot of your prescription, put it on your laptop into the tool. Within less than 30 seconds, it will tell you what possible interactions you can have in your prescription. So you don't have to go to Washington manual. You don't have to go open up Google and go through all that. You don't have to tax your brain to do all that. It gives you all that information. So the accuracy goes high, the monitoring goes high, the call-up goes high, patient care becomes high. And something very important, which I'm not covering right now, is telemedicine. Telemedicine is going to be the in thing tomorrow. If you integrate your EHS, which is loaded with AI, and you're doing a teleconsultation in the future with AI, imagine a telemedicine AI can tell the patient things which you're not able to tell at that time. It can pick up facial languages and facial expressions of the patient and give you more information that you're getting from the patient by the patient talking. It can generate the prescription for you. It can plan the investigations for you. And all this is not hocus pocus or Bollywood or Hollywood science fiction. All this is kept in front of you because you should be the final authority and not AI. Only when you approve of it, it is sent to the patient. So your time gets saved, your diagnostic yields increase, your interactions increase, your comfort level with the patient increase, and patient gets a much better care than he would have got without AI. So emergency admissions are reduced by 20%, predictive analytics increase, resource allocation in healthcare can be decided by AI, like what is happening in the hospital in China. So faster turnaround, better diagnostic accuracy, better triaging of patients. So casualty patients can be decided which should go to the ICU and which not before the emergency medical doctor can rush into the scene. The clinical outcomes are
Dr.
better.
Modi,
Your
please
own
finish
clinical
your talk.
efficiency. Yes, sir.
Please finish.
Should I stop here?
You can finish.
Okay, so just one word of final caution. There is nothing which comes on a silver platter. There is a saying that there's nothing like free lunch. So AI is not the mecca of medicine. It's not the end of the world. There are a lot of ethical issues. I'll just touch upon those issues. It's a big topic. My one of my papers is going to be out very soon. Maybe we can share that later. The data that you're sharing on an AI tool, how do you know that data is not being going to be manipulated by the company which is making it, is not going to sell in the market to make more money? So no matter how much consents you take from the company, non-disclosure consent, you really don't know about the data security and patient privacy. How do you know that those algorithms are actually accurate? So when the algorithms from Mayo Clinic have been transferred to India, there have been errors. And just as you revisit the data, the guidelines that you read, you do a meta-analysis, you get a different aspect to those original studies which you have done. How do you know that these algorithms will continue working in the next 10 years more accurately, because the patient profiles keep changing? So this is called as a distributional shift and an institutional shift. So the problem is, how do those distributional shift and drift? So whether this data that you're using, is it valid or not valid? And there is something called as gamization. The AI tool will keep increasing the pressure of the ventilator till the patient's oxygen improves, but not at the cost of causing barotrauma or a pneumothorax. So some ethics are required, some guidelines are required. These data have to be balanced, they have to be revisited, and the algorithms have also got to be updated and revisited, whether they are right or wrong. And some regulatory bodies are required to make sure that these AI tools are not being misused and they are really accurate, and they're not going to replace a doctor tomorrow. Unfortunately, just a point to be noted here is, neither US nor any country in the world, including India, have yet got a legal guideline in place or the law in place which decides how AI should be working, because we are yet in the infancy stage. But important to remember that as of now, the WHO has come out with a 300-page guideline. ICMR has come out with its own guideline, and India is one of the countries which is going to be coming out with this organ with this committee to decide. And I have contributed a part of it in the meeting when I had with the National Law University. So all this data is being collected from doctors and other people. But as of now, if something goes wrong with AI output to the patient, it is you who will be answerable, not the company which is making the AI. So I'll move fast here. So
Please
bottom
finish.
line is,
Dr. Modi, please finish. We are getting late.
yes, sir. So thank you very much for this opportunity. I just want to conclude that AI is here today and it will be there tomorrow. It's not a wow, it's a how. And remember, you are the final authority and not AI. So thank you very much for the opportunity. And it's just a way to open up and give you a bird's eye view of what AI is all about. Thank you very much.
Thank you, Dr. Modi, for your wonderful session on AI and medical practice. And you have beautifully illustrated how it's shifting from evidence-based medicine to data-based medicine and its implications in how it enhances diagnostics, it helps in precision medicine, research, and conferences and all. Beautiful, very nice. And I just wanted to know one thing from you, like it's very important for us as a doctor to know which AI tool to use. I mean, so that knowledge is also very important. Is that true?
As of now, there is no FDA or Indian authority approved tool that you can use. We are developing a lot, but today we are using ChatGPT, Grok, Perplexity, and Claude. So I'm also using it. Just remember one thing, we need to understand that these are LLMs. LLM is large language models. They derive their information from a lot of internet searches which are done by everybody. They have not been trained on medical literature. So sometimes you get wrong answers. That's called as hallucination by AI technically. So like sometime when I put in the patient data, it told me that the EGFR of your patient is 1430, which is impossible to obtain. So whenever you're using these AIs, you need to put in the right prompt to this AI, and they actually help you pick up many things which you can't. Like I create a diet sheet of my patient, and I don't tell my patient that I don't tell the chat GPT that see HbA1c is 8.8, blood pressure is 150/90, give me the diet sheet. No, I tell the patient he's a South Indian, he's a truck driver, he can't eat outside the dhaba for 4 days. I want the calorie count to be restricted to this. I want a weight loss of this, and I want a carb counting to be this. And I know that he loves paratas, he loves bhindi ki sabji, and he loves aloo dum. So having that in mind, you design a diet sheet for the patient, which will help him because he has to eat in dhabas. He doesn't have to. He can't eat home food. So it actually gives you a 10-day diet sheet, which is fantastically made. I've got fantastic results, but I don't give it to the patient. I run it through my dietitian. Only when my dietitian makes changes or approves, then I give it to the patient. But the results are superior than just giving it to a dietitian. Only thing, remember that whenever using a generic LLP, remember you are the final boss and not the generic LLM. And the most important point is whatever you use, the answers will be very different if you don't give a good prompt. So the whole game lies in how to prompt. It's like you're having a very intelligent resident RMO in your hospital. If you really don't know to get mileage out of it, you have to ask the right questions or he'll give you the wrong answers. So there is something called as prompt engineering, which we are running classes. We're taking certified courses through our I'm a co-founder of Doctors A and Docentra. We have already covered 1 or 2 batches, and where we teach prompt engineering as one of the part of the curriculum. And just to let you know that prompt engineering is a branch of AI which is being prompt engineers are being employed by top companies today in India and abroad. And you know how much they're getting paid? They're getting paid 7 lakhs to 15 lakhs per month because they can decide how the business avenue of the company will go. So when I was asked to create a model when I took my exams for MIT, I was asked to create a model for Ola in Uber as to which driver, which day, which time, which avenues, and which area, which cities should be given more cars, and what should be the efficiency of those cars so that Ola generates more business. So you have to plan out the hospital finances, the insurance finances. Based on that, your company can make it big or not. That's why everything depends on your
With this